Hello, Professor and classmates. My name is Adriana, and I will be presenting the subnote for Week 4 Adult Cardiovascular. My patient is LC, date of birth 3/21/1978, age 47. He's a Caucasian male who presented to the walk-in clinic by self, and he appears to be a reliable historian. My patient comes in with a chief complaint. I have been having increased palpitation for the last few weeks. The HPIs, a 47-year-old male established patient with a past medical history of hypertension and hypercholesteremia, presents with a 2-week history of intermittent palpitation. He describes the feeling as racing sensations in his chest. The episodes can last a few seconds to a few minutes, happening a few times a day. He denies any chest pain or shortness of breath. However, he does experience chest pressure during episodes. He denies any syncope. He reports increased stress with his job as a veterinarian. And additionally, he reports some fatigue as he's not sleeping well. And he has recently cut back alcohol a few weeks ago, 2 to 3 weeks ago. Okay? The patient does not have any significant surgical or hospitalization. He does not have any allergies, and he only takes lisinopril 10 milligrams since 2023. His mother and father both had hypertension, and mother had obesity and anxiety as family history. A social history: he lives with his wife and 4 children, all under 12. His occupation again is a veterinarian. His diet is regular. He has no restriction. He drinks about 1 to 2 cups of coffee a day, but sometimes more. Sleeps 4 to 6 hours. He owns guns, but they're safely stored. He reports that he is now drinking 2 to 3 times a week. However, he does report that he was drinking daily about a month ago because he was really stressed. His stress is really high with work, but he denies any tobacco or illicit drug use. His review system: he denies any fever, chills, or weakness. No recent weight changes, but he does report increased fatigue. He denies any shortness of breath with exertion or chest pain. Reports intermittent palpitations accompanied with chest pressure. He denies any headache, double vision. There's no dizziness or syncope. He denies any cough, any respiratory issues or illnesses. There's no nausea or vomiting, but he does report feeling stressed and some anxiety. The physical assessment: he was alert and oriented and well nourished and in no acute distress. The cardiovascular: he had regular rate and rhythm, no murmurs or clicks, no JVD or peripheral edema. The neurological: he was alert, cranial nerve 2 to 12 grossly intact, no focal deficits, and there was no tremors. Respiratory: clear. His lungs were clear and auscultation bilaterally, no rales, no rhonchi, no adventitious sounds. The GI: bowels were normal active. There was no distension, there was no bloating, there was no tenderness all over all 4 quadrants, and there was no tenderness, especially in the right upper quadrant around the liver, and no pain. Skin was dry and warm to touch, and the patient did appear a little mildly anxious, but he was cooperative throughout the exam. The EKG that was done in the office showed the patient was in sinus rhythm. The heart rate was 88. There was no ST or T-wave abnormalities. There was no abnormal extra heartbeats and seen in the 12-lead tracing that we performed. Vital signs: I missed to tell that they were all within normal range when we performed them. We did do a CIWA, which it was for alcohol use disorder, and it suggested mild results. We also did a GAD, GAD-7, and suggested moderate anxiety. So for this patient, our main diagnosis, we decided to do palpitations unspecified. This diagnosis was the one of choice as the patient presented with those racing feelings in his chest, with that chest pressure that intermittently happens, and both caffeine, alcohol uh, can also increase cardiac arrhythmias to the patient as well as high stress. And additionally, we did an EKG in the office that did not show any abnormalities. So palpitations will be our main diagnosis. However, we do have two other diagnoses: alcohol consumption, alcohol dependence withdrawal, and this condition is could happen because the patient abruptly stopped drinking, and it could cause insomnia, tremors, nausea, vomiting, anxiety, and a lot of monitoring and support from clinicians. It's crucial. Interventions and recognition is essential at this time. Anxiety, it's my third diagnosis, and this one goes hand in hand with the patient's stress, lack of quality sleep, caffeine consumption, and reduction of alcohol. Okay, and I apologize for my dog. Again, the main diagnosis is palpitation. We would like to do labs for my patients: CBC, CMP, TSH, at magnesium. The treatment will definitely include telling my patients to reduce and eliminate caffeine and alcohol intake. This will help with the palpitations and definitely with the reduced anxiety. We'll address stress management to incorporate deep breathing, meditation. We'll encourage increased physical activity, moderate exercise, sufficient sleep, heart healthy diet, and staying well hydrated. Maybe keeping a log for palpitation and blood pressure so we can identify the patterns and the triggers and the stress level. At this time, we felt it was important to address anxiety, so we did prescribe our patient with fluoxetine 20 milligrams, one capsule once a day for 30 days and 2 refills. The patient will be educated on monitoring any symptoms. We again encouraging decreasing alcohol consumption and caffeine. My patient should be coming back in 1 to 2 weeks to discuss the results of the diagnosis. We also are gonna start a Holter monitoring because possibly we'll do a cardiologist referral. The patient should call ER or go to the ER, call 911 if he experiences any sustained palpitations or any shortness of breath at rest. Thank you.